good evening all. Thank you, Anant Ramaswamy boss and other organizers for the opportunity. So today we are going to discuss now in this my talk current evidence for dose modification based on available tools in older cancer patients. So as we already discussed these things, and as per the 2012 registry, there are new cases of cancer were more than one third in the 75 or more than 75, which is expected to increase more than 50% by 2050. So most frequently seen cancers in older individuals are in women, breast and colorectal, while in males, these are the respiratory and the prostate cancer are the most common cancer in geriatric population. From 1900 to till now, we have 19th century till now, we have progressed from chemotherapy till now, CAR cell therapy, biospecific antibodies and cytokines. So does everyone benefit from the systemic treatment? Usually the population is heterogeneous, not homogeneous, as we see in the trials registrations that population. So patient fit and PS01 usually are presented in the clinical trials, and the rest which are seen in the community are the older or frail patients for which I think need a geriatrician, like pediatrician for the pediatric patients and geriatrician for the geriatric patients. What is altered in the geriatric patients? There is a change in the pharmacokinetics and drug absorption. These are the some are the modifiable factors and some are the non-modifiable. Modifiable reduce gastric acid, a smaller bowel surface area, splanchnic blood flow decrease peristalsis, decrease gastric emptying, and non-modifiable factors. Modifiable, there is a polypharmacy, concomitant medicines, and other the gastrointestinal physiological changes, which may lead to the altered pharmacokinetics. So aging causes the decreased absorption of the drug. Distribution is also changed according to the fat and other factors. Decreased metabolism and the elimination of the drug is also reduced in aging population. The patients of elderly, because of these factors, are at increased risk of myelosuppression, mucositis, cardiac depression, peripheral neuropathy, central toxicity, decline organ function, and so on. So these are the geriatric domain which are assessed during a geriatric domain, which usually are assessed in the comprehensive geriatric assessment or assessment of function, which is because of the instrumental activity of daily living, comorbidity, which can be assessed by the history or validated tools. Falls, single question of fall is sufficient. Depression by the GDS scale, cognition by the mini-cog or BOMC, and nutrition is unintentional weight loss. The integrated tool which integrate these all the factors are usually the CARG, CRASH, G8, VAS13, and the e-prognosis to tell about the mortality. So geriatric oncology tool assessment of the function. We assess the function by the instrument activity of daily living. The instruments are the CAT activity of daily living and LOT and GH are the most commonly used. It measures the ability to complete the given task or to maintain the independency in the community. And dependency on any task is signifies the impairment. So IADL is usually if it is less than 5 CAT index, it is abnormal, or IADL it is that means Lawton IADL is 7 or less than 7 is considered as abnormal score, and this also predict the chemotherapy toxicity, mortality, and hospitalization, functional decline. These are not the randomized trial which I have given the references. Some are the observational studies, some are the extrapolation of the data from the studies of the older. Second is the falls. This is the single question of fall that in last 6 months, how many times the patient fell. This can assess the patient's assessment of fall that indicates. So this is also associated with the chemotherapy toxicity. If we go by the some data as per the references that 65 plus patients, the 1 out of 3 patients usually have the history of fall in a year. 72 plus patients fall every 2 years, and age 80 plus patients usually fall every year, at least one time. To assess the mortality, we have the Charleston Comorbidity Index. Now Charleston Comorbidity Index that is updated, or you can say the Advanced Charleston Comorbidity Index. Most commonly used are these. Other are the CIRSG and Adults Comorbidity Evaluation. So abnormal in this any comorbidity index is associated with the poor survival in a cancer patient with an increased chemotherapy toxicity and the hospitalization. So any item is of the Charleston Comorbidity Index is abnormal, then it is considered abnormal. So score even 1 is also an abnormal score. For the cognition, we have that assessment test with the mini-metal status examination. Although it is a lengthy examination and it takes time, so we can take consideration of the mini-cog or BOMC, Blessed Oriental Memory Concentration Test. Mini-cog is only abnormal test which identify the 3 recall words that we can call 0 or 1 or 2. If that patient is recalling 0 words only, then this is also abnormal. If 1 or 2 words are recalled plus abnormal clock drawing test, then is also a abnormal test. And this cognitive assessment is also poor cognition is also associated with the poorer survival in the cancer patient, because they have the incapability in the decision of the treatment, and also they are not cannot be assessed on the same time the chemotherapy toxicity. They are poorer in telling the story. We can see in the routine practice also. The patient for the assessment of depression, this is a geriatric depression score. This is the X score of the 15. So if the patient is having a score of more than 5 on this score, it is considered as abnormal. 6 to 10 is a mild, moderate, and 10 to 15 is considered as a severe depressed score. For the nutrition, the unintentional weight loss, more than 10% of weight loss from baseline is considered as a abnormal nutrition or undernutrition patient. So poor, this is also associated because as we see in the previous slide that it can affect the drug distribution in the body, and also the free form of the drug is also erratic, so the erratic behavior in the condition of poor nutrition. So in this patient, why we do not consider the ECOG or KPS performance tests alone? So study name I cannot read fully, for that's a story very typical for me. That so you can read this. This is the study where the elder person of 70 or more than 70 years with a PS of 0 or 2 ECOG online and a stage for non-small cell lung cancer were randomized to doublet chemotherapy. That means this was chemotherapy allocation based on PS and age. and treatment allocation based on the comprehensive geriatric assessment. In this trial, they took the two separate arm of the chemotherapy. One was the platinum doublet for the patient is the 70 less than 75 and PS less than 1 or 0 or 1 or less than 1, or another arm with the more than 75 with the docetaxel, and both arms were also evaluated for the comprehensive geriatric assessment, and then they were randomized for the toxicity and the survival. So patients in the comprehensive geriatric arm, they did not differ in the survival, but the toxicity was toxicity was lower in the intervention arm, and we can see it was 85.6 versus 93.4. Grade 4 or 5 toxicities were observed in this trial. So but the treatment time to treatment failure free survival was not different, and also the overall survival was not also different in both arms. So this was again the GAIN study, geriatric assessment intervention study, with the impact of geriatric assessment on chemotherapy toxicity. In this trial, the patients of the age 65 or more with all solid tumor, all stages, who were planned to start the new chemotherapy, underwent the baseline geriatric assessment, and they were randomized in the 2:1 fashion, and patient experimental arm underwent the usual care for the geriatric assessment driven intervention, plus and the control arm was the standard of care. So patients were followed until the end of chemotherapy or the 6 months post initiation of the chemotherapy. So primary endpoint was the grade 3 to 5 toxicities, and the secondary endpoint was advanced directive completion, unplanned hospitalization, emergency visits, and average length of hospital stay. These were the results of this study. That this study met its primary endpoint achieved, and there was a significant difference in the toxicity grade 3 to 5 in the intervention arm versus the control arm. It was a 50.5 versus 60.4%. If the hematological toxicities were also quite higher in the control arm, it was 19.3. And another point that this study achieved was the advanced directive completion. The 70% patients in the study arm completed the treatment, and it was 59% in the standard of care arm. But other parameters, there was no difference in the both arm, ER visits, hospitalization, or average length of hospital stay. This was another study, GAP 70. In this study, the age criteria was slightly higher, around 70 plus, incurable stage 3 or 4. In this study, patients were taken more than one geriatric assessment domain impaired out of 8 domains, and other than polypharmacy, starting new chemotherapy or other agents with a similar prevalence of toxicity. 718 patients were randomized. In the intervention arm, oncological physician was provided with the geriatric assessment summary and geriatric assessment guided recommendation for each enrolled participant starting new chemotherapy with similar prevalence of therapy, and another arm was the standard of care arm. Although the treating oncologist was blinded for the arms for the toxicity, so endpoint was a clinically related grade 3 to 5 toxicity, and the survival was also taken into account in this study at 6 months, and otherwise the treatment decision, functional and physical decline, and patient reported toxicities. In this study, median domain which were abnormal was 4 out of 10. Most of the cancers were the GI cancers, and patients achieved, there was a difference in the toxicity. Overall toxicity difference was a 58.1 versus 71%, while it was mostly driven was the non-hematological toxicities, that was 31.8 versus 51.8, although the survival at the 6 month was not different in both arms. So these are the integrated tools which integrate all these domains into this. These are the CARG, which is having all these parameters: age, cancer type, comorbidities, HST, fall, and hearing, and lab parameters. So the patients, for the validation of this tool, 500 patients aged 65 or more years with cancer from 7 institutions completed a pre-chemotherapy assessment and captured the socio-economic, socio-demographic, tumor treatment variables, laboratory test results, and geriatric assessment variables. So patients were followed through the chemotherapy course to capture grade 3, 4, and grade 5 as defined by the national CTCI criteria. So the domain was, one was the age in this group, otherwise treatment tumor related was a type of the tumor. GIGU have the higher toxicity among the elderlies. Chemotherapy dosing, standard dose or the monotherapy versus standard therapy. Laboratory values considered were the hemoglobin and the creatinine clearance, which is the most effective measure. And the geriatric assessment, falls, hearing impairment, IADL, and decreased social activity. These were taken into the account. So risk of toxicity by the total score of the CRG, it was low, medium, and high. Low score was calculated up to the 5, that was 30% which patient have chances of 30% chance of grade 3 to 5 toxicities. And the medium, it was 6 to 9. It was 52% of the grade 3 to 5 toxicities were observed. And high risk group observed 83% toxicity of grade 3 5 by the chemotherapy. But the scoring system was built, which has considered the median of the score 7, below which the patient considered that patients may have the lower toxicity versus the higher toxicity. The score 7 was taken as an account. Another tool is the CRASH. So CRASH tool, it provides the estimate separately for the risk of grade 3 hematological and grade 3 4 non-hematological toxicities. For hematological parameters, it takes diastolic blood pressure, the 72 is the cutoff value, IADL score less than 26, and LDH, and assessment of risk of non-hematological toxicity with ECOG performance status, MMSE, and mini nutritional assessment. Chemotherapy intensity is assessed with the MAX2 index also. The CRASH scale includes GA measures known also to predict other adverse outcomes. For the CRASH score, in this prospective multi-center study, 70 plus year patients were taken and 500 patients were evaluable, were split randomly into 2:1 fashion into a derivation cohort and a validation cohort. So CRASH score was conducted along the two subscores, H and NH toxicity. Predictors of H toxicity, as we have discussed, H and NH toxicity. So predicting the risk of toxicity, the diastolic blood pressure cutoff was 72, and the LDH, it was 0 to 59, IADL, it was 26, and ECOG performance status 0 or more than 0. It was mini mental status examination 30 versus less than 30, mini nutritional assessment 20, less than 28 or more than 28, and chemotoxicity in 0.44 versus more than 0.44. So this was the CRASH model risk categories: low, medium, medium to high, and high for the hematological toxicity, non-hematological toxicity, and for the overall. This is the G8 screening tool, which is taken as a screening tool to assess for the geriatric assessment. So items are these are the in table form: the age, weight loss, food intake, morbidities, neuropsychological, and body mass index. Into these are all the measures. So it should be noted that the G8 tool is not aimed at replacing expertise of geriatrician for the diagnosis of frailty. Rather, it should be used as a screening tool to identify patients in need for a further assessment and appropriate care. Total score is 0 to 17, and it is considered if it is 14 or less than 14. This effectiveness of this geriatric screening was assessed in the adjuvant and patients on aromatase inhibitor in the breast cancer in adjuvant setting. So it quite accurately predicted the toxicity with the arthralgia and other toxicity. The concordance was significant between the G8 and the adverse outcomes. So sensitivity was 78% of this G8 and specificity was 81%, with the positive predictive value of 70% and negative predictive value was 87%. So G8 can be taken into account as a screening tool for the comprehensive geriatric assessment. If it is abnormal, then patient should undergo complete geriatric assessment at least. But if the geriatrician wants to assess without even in normal G8, then it is up to him and it should be done. It cannot replace his decision. Another integrated tool is the WEST 13. These 13 items tools include the age, self-related health, common functional tasks, and ability to complete the physical activities. A score of 3 or more than 3 is associated with the mortality and chemotherapy toxicity in older patients with cancer. A score of 7 or more than 7 has been shown to associated with the functional decline. So WEST 13 can also be used as a screening tool. Another are the short physical performing battery test and time up and go. These tools should be used if we have enough time or enough resources in a OPD, because these are the time taken tools. Another is other than chemotherapy in this era, we are having targeted therapies. For this, we have not a randomized trial, but these are the pre-tox study, which assess the domain of which patients of the retrospective and the prospectively multicentric study in patients age 70 year or more. Primary endpoints were the incidence of severe toxicity. It was assessed in the solid tumors, lung, breast, and sarcoma. So all TKIs were taken in the retrospective and prospective. These are all TKIs and the angiogenic TKIs. So 41 in this study, the 41% of the patient having more than one severe toxicity with the different treatment discontinuation was there in 68.5% of the patients, and persistent or significant disability was in 22%. In this study, we found that there are the concomitant medicines. If cutoff value of 3, if it is more than 3, it was significantly associated with the toxicity with the targeted drugs with the TKIs. This was the waterage study, which was done to assess the maximum tolerable dose of pazophenib, which is 800 milligram per day in a normal population, or you can say adult population. But this was done in the 3+3 fashion, where if the patient were having 0 or 1 dose limiting toxicity, then the patients went again for the 3 more patients and then assessed for the dose limiting toxicity and maximum tolerable dose. So this was the toxicity was assessed by the drop of 2 or more than 2 points in an ideal score of the toxicity. In this study, we found that the 600 milligram per day dose was associated with only 1 dose limiting toxicity. At higher doses, there was 2 or more than 2 dose limiting toxicity were observed. So elderly population, this study suggests the 600 milligram per day pazophenib is sufficient to get the results nearby equal to younger population. So era of immunotherapy, we have the 3 types of immunotherapies: anti-CTLA4, anti-PD1, and anti-PDL1. Now we have the CAR T cell therapy also. So problem with the immunotherapy is the increasing in the elderly people, the increasing burden of the comorbidities and immunosenescence and dysregulation of, and very less representation in the clinical trial, and mental health and social support networks, metabolic changes, and overall functional status in elderly. The effect of immunotherapy in older adults, we can see that the patients were having, there is a decrease, the antigen represented, there is decreased tumor release, the decreased antigens, antigen release is decreased by the tumor in the elderly. So this is antigen presentation on the T cell is also decreased. That causes the decreased activation of the T cells, and eventually this causes the decreased efficacy against the tumor cell or tumor development in patients or elderly individuals. So immunosuppression could impair each step of the anti-tumor immune response. So that's why this may affect the efficacy of immunotherapy in older individuals. So age-associated changes, we can see that the young thymus support the more thymopoiesis with the naive T cells, while the elderly people are having the less naive T cells, while memory T cells are more, and that give rise to the activator effort T cells, which are oligoclonal and have the most restricted T cell receptor repertoire. So this results of immunosense and inflammation on immunotherapy. It leads to a dysfunctional immune response, and chronic antigenic exposure is equal to that is immunosense. Low grade inflammation, tumor and cell change damages, immunoserver escape, and tumor development happens in the elderly individuals because of this immunotherapy effect. This is the approach to the decision making based on the geriatric assessment. If the patient is having a life expectancy that pull him or her at moderate or high risk of dying or suffering from the cancer during the lifetime. If it is not, then the patient can be managed symptomatically. If yes, that does the patient having decision making capacity? No, then other we can obtain the information with the supporting relatives or other the ethics committee. If the patient has the decision making capacity, then all the patient's goals and the values consistent with availing cancer treatment, no, or then patient symptomatic to manage, and if it yes, then risk factor to be assessed in these patients. So if the patient have risk factor for adverse outcome because of the treatment of the cancer? If no, then treatment can be recommended as the disease specific guidelines. If yes, then we should assess the complete geriatric assessment and the toxicity as per the guidelines. So in conclusion, older adults are at increased risk of cancer. Some of them cannot tolerate cancer medication. Fear of toxicity and unexpected side effects limit the use of standard chemotherapy. In patients age 65 or more than 65 receiving chemotherapy, geriatric assessments should be used to identify vulnerabilities that are not routinely captured in oncological assessments. Evidence support at a minimum assessment of function, comorbidities, falls, depression, cognition, and nutrition. Well-designed prospective observational studies have found that items included in geriatric assessment can identify older patients at greater risk for chemotherapy toxicity and mortality. So geriatric assessment-based tools are available that provide a specific estimate for the chemotherapy toxicity, CRG in crash, and the highest risk of early mortality by the G8 and WES13. In my view, as per the available evidences till now, geriatric assessment guided intervention does not improve survival, but it decreases the systemic therapy related toxicities without compromising the survival. These decreased toxicities are translated into the improved quality of life of geriatric patients, which is the primary goal of these studies. Hence, the comprehensive geriatric assessment should be done in all geriatric patients who are undergoing systemic therapy for cancer. Thank you.
Thank you, Dr. Tarachand, for covering the topic exhaustively. We'll have a panel discussion after a break of around 10 minutes. We shall reassemble here after 10 minutes for the panel. Thank you.